we need to get onto all of the excitement with the new drugs that are targeting, and I'm going to let my esteemed colleagues be the leads on each of those. But I'm going to take one for the team first, and I'm going to talk about chemotherapy, because chemotherapy still cures patients. It's just not been optimized, or has not been able to cure the majority of patients. But it doesn't mean we don't have still things to do there. We all know that there's been 40 years of attempts to improve on the outcomes with 7 and 3 and consolidation, and the majority of the studies have been negative. And recently, there's been an exception, and that is giving daunorubicin and cytarabine, except in a new formulation, a liposomal encapsulation of a magical 1:5 ratio of daunorubicin to cytarabine. So this is liposomal daunorubicin cytarabine. The investigators, we all called it CPX 351. And this came from very good preclinical work showing that the molar ratio of the two drugs is very important at being synergistic for cell kill and leukemia cell lines. And some molar ratio is actually antagonistic. And the liposomal formulation allows you to keep that 1:5 molar ratio. The liposome that is part of this agent actually targets the leukemic cells better than normal cells and targets the bone marrow. And so this drug was actually tested first in a randomized phase 2 study versus 7 and 3, and in patients between 60 and 75. And in that initial randomized phase 2 study, there was no statistically significant benefit. But in a subset analysis, patients with poor risk disease, antecedent hematologic disorders, CML, CMML, MDS, or treatment-related AML, those patients appeared to have higher CRs, better relapse-free survival, better overall survival, and lower induction toxicity, mortality. But the numbers weren't sufficient to make it was statistically significant, and it was a post hoc analysis. And so the perfect experiment was done, a well-designed phase 3 study of liposomal daunorubicin cytarabine versus 7 and 3, followed by 2 cycles consolidation with 5 and 2, or liposomal daunorubicin cytarabine. And the study was positive. Overall survival, median was increased from chemotherapy of 6 months up to 9.5 months with the liposomal product. The induction mortality was lower with the liposomal product. The response rates, both CR and CR plus CRI, were higher with the liposomal formulation. And in terms of toxicity, no apparent difference in non-hematologic toxicity, maybe a little bit less mucositis, but a slightly longer time to count recovery with the liposomal product. But patients did achieve CR/CRI, meaning their counts did recover. And what was most intriguing is that in this group of patients between 60 and 75 with poor risk disease, a large number of them went on to transplant. More of them went on to transplant after the liposomal product. And by landmark analysis, the survival of those patients was superior to patients who went on to transplant after 7 and 3 approach. I mean, a large randomized phase 3 study that led to a drug approval. And so I really do believe that in that group of patients with secondary AML, the way I call it, the labels AML with myelodysplasia-related changes or therapy-related AML, we really need to consider the use of this agent to help improve outcomes of our patients. And so 40 years later, we're still optimizing daunorubicin and cytarabine, but I think there really is something to this formulation. Any comment?
I agree, and I just emphasize that the fact that it's the safety profile was actually pretty good. It's very consistent with the chemotherapy. If anything, a few things you saw less, like for example less alopecia and things like that. A little bit more myelosuppression, but nothing consistent. And actually there were fewer deaths related to sepsis and things like that. So it's a good agent. As you said, the mechanism is still the same, but these agents are directed more into the leukemic blasts, and they maintain that molar ratio that's been found to be optimal. So for that population, it's good. Question is, can we expand into that and take it into the de novo AMLs and others? Those studies are going to be happening, And we'll see. Right now, the indication is what you mentioned, and that's where we are using it. But it'll be intriguing to see if we can help optimize the chemotherapy in other areas.
And a new backbone of chemotherapy upon which to test novel agents that we're about to talk about.
Right.
Yep.
Yeah, and I thought this was a very courageous study because they really looked at a very high-risk population, one in which you really would have to go to transplant to expect good outcomes. And there are two takeaways I have from this. The first is the choice of induction matters. You got more people to transplant, the transplant worked better. But the second is transplant you can give to older patients and see good outcomes. And this is one of the few prospective studies that actually had a fairly high rate of transplantation in older patients, and actually that's what was intended and what was delivered on the study. And that's encouraging because the transplant outcomes in patients even over the age of 70 were really quite good. And that encourages us to be aggressive with these patients and hopefully offer them curative therapy.
I just wanted to add one important point, and this touches back on Sasha when we talked about the initial diagnoses of these patients, that at his institute they specifically do FISH for chromosome 5 and 7 abnormalities to look for this particular entity. So if you look at the terminology and the use of this agent, I have a feeling that maybe people are maybe not aware or don't use the drug as much because there's this new entity that they sort of have defined as AML with MDS-related changes. And I think going back again to our initial discussion, in order to get the benefit of this drug, which is a proven benefit in this phase 3 clinical trial for this subset of patients, it is essential that at the time of diagnosis that your hematopathologist and the clinicians are specifically looking for MDS-related changes, whether it's a prior history of myelotoxic chemotherapy for any reason, or a cytogenetic abnormalities, which are diagnostic of the MDS-related changes. In fact, people often use the word secondary AML because that's something we're more familiar with, but it may be that a specific number of patients with this particular entity are not recognized and are therefore going ahead and getting 7+3 as their initial induction chemotherapy instead of the liposomal. And I think that that's something that we need to be aware of, and we need to specifically ask for. In addition to FLT3, IDH1, IDH2, we need to talk to our pathologists and our cytogeneticists and clarify, is this an MDS-related entity?
Yeah, again, a very good argument for waiting for this information to help you pick the best therapy, and day one matters.